ท่านที่2นะครับในช่วงเซสชันถัดไปนะครับเราจะได้รับเกียรติจากวิทยากรต่างประเทศนะครับในการบรรยายในหัวข้อของการ apply AI สำหรับ medical practice นะครับแล้วก็การนำ AI ไปใช้ในช่วยในด้านการผ่าตัดโดยเฉพาะการทำ 3D printing นะครับระหว่างนี้ผมจะขอมอบเวทีให้กับmoderator 2 ท่านนะครับท่านแรกนะครับผู้ช่วยศาสตราจารย์ดร.นายแพทย์จิรวัตรสว่างศรีนะครับอาจารย์เป็นหัวหน้าศูนย์นวัตกรรมของภาควิชานะครับและอาจารย์ยังเป็นศัลยแพทย์คนแรกนะครับที่ทำ ESD ในประเทศไทยนะครับแล้วก็ยังเป็นศัลยแพทย์คนแรกนะครับที่ทำ T-field lymphadenectomy นะครับของ esophagus นะครับอาจารย์ก็จะมาเป็น moderator ให้เราในเซสชันนี้นะครับสำหรับอาจารย์ท่านที่2นะครับผู้ช่วยศาสตราจารย์นายแพทย์ธีรพงศ์โตเจริญโชคนะครับอาจารย์เป็น CVT นะครับแล้วก็อาจารย์เชี่ยวชาญทางด้านศัลยกรรมเกี่ยวกับ congenital heart disease อาจารย์เพิ่งจบมาสดๆร้อนๆจากแคนาดานะครับที่จากโรงพยาบาลHospital for Sick Children นะครับเดี๋ยวขออนุญาตมอบเวทีให้กับอาจารย์ธีรพงศ์อาจารย์จิรวัตรครับขอบคุณครับ
ครับขอบคุณครับอาจารย์ธนากรครับ Welcome to the international session. The first speaker, Dr. Tomohiro Tada. He is a CEO. Hello, Dr. Tada. He is the CEO of the AI Medical Japan. He is a pioneer of the innovation for AI for diagnosis of GI cancer. And he first developed for real commercial and for usefulness for real patient. His AI Medical Japan also have a collaboration for the research with the Sirirat Hospital also. Please welcome Dr. Tada. Can start the lecture, please.
Today I will talk about applied AI for future medical practice. I'm an endoscopic doctor, so I will talk about focusing in gastroenterology. This is my COI. So today I will talk about AI and big data in gastroenterology and its real-world implementations. At first, I will talk about AI for big data in gastroenterology. This is a hype cycle showing the evolution of technology in 2018. Deep learning was the peak of expectations. You may remember that in 2018, AI was all we had in the news. The hype cycle, which shows the evolution of technology, has changed like this in 2024. Generative AI, as typically by ChatGPT, is already beyond the peak of expectations, and quality are quickly entering in the stage of social implementations. And a new innovation, such as autonomous AI, is accelerating in research and development. Just as horse-drawn carriages were completely replaced by cars within 10 years, at the fourth industrial revolution, AI and big data are entering real life. The era will come when it will no longer be acceptable for doctors to perform diagnosis and treatment alone without AI. So what exactly is big data? Big data is well defined by 3 V's: volume, variety, velocity, augmented recently by value and velocity, comprising the 5 V's. The medical field is increasing, utilizing the power of big data. In oncology, the use of big data is prominent. The Cancer Genome Atlas program, TCGA, is a leading example. To date, TCGA characterized over 20,000 primary cancers and matched 33 cancer types. AI plays a significant role as we harness big data. Deep learning can analyze image and extract features faster and more accurately than humans. And to take advantage, more health systems are beginning to store clinical data to train AI. From endoscopic image to historical data, the integration of AI-powered big data in the GI field showcased remarkable advancements. Today, next, I'll talk about AI research and development. This slide shows a 5-year survival rate for gastric cancer in Japan. When diagnosed at early stage, like stage 1, 5-year survival rate is 97%. However, prognosis worsens significantly at later stages, underscoring the crucial need for early detection. And detecting gastric cancer at early stage is challenging, as many early lesions are flat and blend with existing stomach inflammations. The overlapping signs make it hard for lesions to stand out clearly. So, early diagnosis requires careful attention to these subtle signs. Here is a lesion in this image. In 2018, we published the world's first paper on the use of AI in detecting early gastric cancer in still images. We trained AI using 13,000 images and validated 2,000 images, finding a sensitivity of 92.2% across all regions, and especially 98.6% of regions exceeding 6 millimeter in size. Recently, our first product, GastroAI Model G, has obtained approval from PMDA in Japan, and also we get approval from Singapore in 2024 February. Revolutioning real-time detection and diagnosis of early gastric cancer during upper GI procedures. And this is the movie of our product. Like this, early gastric cancer is hard to detect even for experienced endoscopic doctors, but AI support to detect early gastric cancer like this, mark up the suspicious site for gastric cancer. It is like in these days, doctors only perform endoscopic examination by himself, but our AI can support doctor during endoscopic examination to detect gastric cancer at early stage. If marked up like this, endoscopic doctors can easily find early gastric cancer. So the next movie is our AI. This is only gastric funded grand polyp. So AI shows low confidence. This means there is no suspicious site lesion for gastric cancer. This is only an erosion. So our AI shows low confidence. This is not suspicious for gastric cancer. And this is also severe atrophic gastritis. So our AI shows, and this is only a gastritis. So no lesion for gastric, suspicious lesion for gastric cancer. So in comparative study, AI outperforms both specialists and non-specialists in Japan of Japanese doctor in sensitivity diagnosing early gastric cancers. And for accuracy, it demonstrated superiority to non-specialists and non-inferiority to specialists. Our AI showed sensitivity better than specialists and non-specialists in Singapore data. Our AI showed accuracy equal to specialists and better than non-specialists. And this is a randomized control study of our AI in Japan for diagnostic performance among non-experts. The accuracy was higher in AI group than in non-AI group. The result of this research are currently being submitted for publication and will be presented in more detail in in that article. Personally, I think the most noteworthy point is that all cases where AI had changed the doctor's judgment, it changed in the direction of reducing the number of overlooked cancers. Across 21 studies, AI demonstrated remarkable sensitivity and specificity in detecting early gastric cancers, 90% and 90% retrospectively. Remarkable is with assistance of AI, the sensitivity of non-specialists was significantly improved from 64% to 74%. Examining AI performance in the esophagus reveals consistently high sensitivity, particularly for esophageal squamous cell carcinoma, ESCC, with sensitivity and specificity exceeding 90%. A Chinese group conducted the first tandem RCT for AI for esophageal squamous cell carcinoma, whereas the AI first group had a higher detection rate. This is a tandem RCT study using AI based on 96 videos of Barrett esophagus. The result shows that AI enhanced non-expert endoscopist performance, raising sensitivity from 90% without AI to 70% to 78% with AI. Unlike the AI product for colonoscopy, commercial offering for upper GI product remains limited. In Japan, only Fujifilm and our company provides AI for gastric cancer. These are other AI for stomach cancer that have been researched and published in journals, but there are significant barriers between research and development and to getting medical approval and commercialization. In contrast to upper GI, the lower GI has multitude of AI solutions, and these AI detect chronic polyps during endoscopic examinations. AI's performance in detecting colorectal polyps is well documented. This meta-analysis study reveals that the adenoma detection rate ADR was higher in AI group than in standard group, 44% versus 35.9%. This corresponds to 55% reduction in miss rate, polyp miss rate. In other words, with AI, we can reduce the half of the missed polyp. This multi-center RCT in Japan evaluated the impact of AI on improving endoscopy quality for colonoscopy trainees. Results shows a lower adenoma miss rate in the AI group compared to the non-AI group at 25.6% versus 38.6%. A Canadian group conducted an RCT of colorectal polyp and comparing autonomous AI to AI-assisted human optical diagnosis. Autonomous AI achieved higher agreement with pathology-based surveillance intervals. This study presents a question if only AI performs better than AI plus human. A newly published study in Science alarms that nearly 80,000 Americans die or are permanently disabled by diagnostic errors each year. Using AI in colonoscopy reduces the rate of missed polyp by 50%. It requires only 10 seconds. In my opinion, AI's usefulness in medical field is quality assurance. To secure safety, several AI-driven solutions are emerging to ensure the quality control of upper GI examinations, ranging from anatomical classification to the detection of blind spots. Noteworthy is the development of AI system for assessing sensitivity in ulcerative colitis, where findings shows high correlations between UCEGS inflammation score and Mayo endoscopic score, and between IBD expert and AI. This is a prospective study for AI-assisted reading versus standard reading in multi-center instruction for capsule endoscopy. AI-assisted reading was superior to standard reading in accuracy and reading time. Another AI in gastroenterology. AI for histological diagnosis in UC, ulcerative colitis, advanced system for distinguished histology activity in UC underscore AI's expanding role in diagnostic tasks. In addition to visual recognition, AI's applications extended to human language processing, broadening its scope of utility in healthcare. AI's remarkable accuracy in assigning surveillance intervals for upper GI procedures far surpassed traditional methods, showing its potential for optimizing patient care pathways. Google's innovative AI healthcare model, MedGemini, sets a new benchmark in understanding medical context, outperforming its competitors. Lastly, I will talk about real-world implementations and prospect. As we embrace the potential of big data in healthcare, it's imperative to acknowledge its inherent limitations, including privacy concerns and data quality issues, and the need for a skilled person. Similarly, for endoscopic AI, while transformative, is not without its constraints. On the left, you can see some examples of where AI may incorrectly respond. AI may react severe atrophy, severe redness, or bubbles and so on. But we can, as a trained endoscopist, we can deny this is a false negative. This is a study for how AI would influence doctors' medical decision making with 21 endoscopies. When AI was correct, the endoscopist follows its advice more than when AI was incorrect. This indicates that the influence of AI is likely to have a positive effect on diagnosis. I think this result is made possible because doctors with specialized knowledge use AI assistant. Here is the policy for AI-based image recognition technology from JGS, Japan Gastroenterological and Endoscopy Society. It clearly states that AI technology is a way to support the diagnostic functions of detection, not aid the endoscopic skills of endoscopists. In other words, AI is a diagnostic aid, not a replacement for endoscopic operation techniques. The final diagnosis is made by doctor, so it goes without saying that they must have the knowledge to make their own judgment. Meanwhile, ESG, European Society for Gastroenterology, the position statement expressed that AI-assisted detection rate should be comparable to that of experienced endoscopists. Endoscopic AI should bring up performance of non-expert endoscopists to that of expert endoscopists. This is also a reasonable statement in the sense that unless AI has a sensitivity at least comparative with above that of specialists, it will not lead to improved accuracy. It's essential to understand fundamental differences between AI and humans. While machines interpret consistently based on programming, humans' interpretations are more dynamic with time and context. Temperature interpretation is a good example. As such, by understanding the limitations of AI and utilizing it as a tool to support human wisdoms, we can move forward to enhance human capabilities. Looking forward, collaboration between AI and medical professionals will reshape healthcare delivery. AI enhance human expertise, while we fill in any gap AI might have. Together, we strive for greater precision and efficacy in patient care. And this is my final slide. In summary, the integration of big data and AI makes a significant shift in healthcare, notably evident in advancements within gastroenterology. AI promises to be an essential partner for all healthcare practitioners. So, thank you for your attention.
Thank you very much, Dr. Tada. Congratulations with your product of the for innovative healthcare. It will improve the survival outcome of the cancer patient as well, and we hope to can use your product for the real practice in near future. And
Yeah.
hope our collaboration will success and create some the paper for about the AI for endoscopies for Thailand doctor also. Thank you very much. Any question from the floor, please? I have one question, Dr. Tada. What do you think in the progression of the future of the AI more than nowadays? I think you are like a prototype first, and you develop for the second and third generation. And today I saw your AI can suggest of the treatment. What do you think in near future? Does it can improve the more of the facility of the AI for healthcare?
Thank you for your question. Our first product is to support, detect suspicious lesions for early gastric cancer. And so we are focusing on the next product will be the differentiate capability. If AI just pick up the suspicious reason for early gastric cancer, and next AI will be differentiate that this region is really cancer or not. And other AI is and research and developing rapidly, and like quality control. If this image is correctly captured or clearly captured, or if you look entire stomach thoroughly, and AI could check these points. And so after that, AI will support the medical decision, like this region is cured by endoscopic resection, or this region should be treated by surgery. And so AI has a big potential to support every area in medical field.
Okay, thank you very much, Dr. Tada. I hope it's really useful for also both side, for doctor and for patient also, for improve their health quality of life. Thank you very much, Dr. Tada.
Thank you very much.
Okay. We will move on to the next speaker.